plenary lecture number 9 about damage control surgery for perforated diverticulitis by Professor Raymond Strohal from Austria.
Hello, ladies and gentlemen. Dear Chairman, thank you very much for inviting me once again to this fantastic meeting. Today I'm going to talk about damage control surgery for perforated diverticulitis in peritonitis. It's not going to work. Excuse me? Not working. Nothing working. No. I have no conflict of interest. We all know what diverticulosis is, and it's a very common disease these days, especially in the Western world, and up to 66% of the population is afflicted by diverticulosis, especially in the elderly patients. In the Western world, usually the sigmoid colon is affected, whereas in Asia, the right hemicolon is associated with diverticulosis. Most people remain asymptomatic, but up to 25% develop symptoms, and of those, 15 to 25% develop significant complications. The pathogenesis is multifactorial, and we don't understand it yet fully. So the historically accepted low-fiber diet is there, and as well the colonic dysmotility in patients with constipation. And then we are talking about the high pressure zone in the sigmoid colon, due to the increased intraluminal pressure, and then as well morphological changes and genetics, obesity nowadays, a high topic as well, reasons to get diverticular. So you can divide the diverticulosis in asymptomatic and symptomatic. I already said that about 25% have a diverticulitis. But there is one group we should not mix up. It's the segmental colitis associated with the diverticulosis, but the diverticulum itself is not afflicted by it. So doing a sigmoidoscopy, there is no pus coming out of the diverticulum. So these kind of entities should be treated by the gastros, and it's more a colitis than a diverticulitis. Then we have the uncomplicated and complicated diverticulitis and all the other effects we have. So you can classify the diverticulitis using either Hinchey classification, which is the most used in the world. It's an intraoperative diverticulitis, and I'm concentrating on stage 3 and 4, the generalized peritonitis and the fecal peritonitis, due to a perforation or a free perforation. In Central Europe, Stock-Hansen is used as well. This is a radiological classification which starts with stage 0 with the diverticulosis and ends with the recurrent diverticulitis, which is a topic at itself. So the treatment, well, historically it started with Mayo in 1907. He used a 3-stage operation, so he did a diverting colostomy and drained the pus, then resected in another operation the involved colon and did afterwards a colostomy closure. In the 80s, the Hartmann's procedure was used for diverticulitis and perforation as well. Initially, it was used for treatment for colon cancer, for rectal cancer, as a 2-stage procedure already. So we all know it. You resect the diseased segment, you construct a colostomy, you close the distal rectal stump, and do the Hartmann's reversal afterwards. Then already in the 90s, the resection with the primary anastomosis with or without a loop ileostomy came up. And in 1996, Ferranda published for the first time the laparoscopic peritoneal lavage and placing a drain only. So especially the Scandinavian and countries and Dutch people were really enthusiastic about this procedure. In the center of Europe, we started a bit later on, and we were a bit, we didn't really know what happens to all those patients, so more conservative. But I think there is this publication from Snijders from Holland, head of printing, and he could show for the long-term diverticulitis a high recurrence, re-intervention, and readmission rate. So I wonder if loads of people are going to do the lavage again, or still propagating it to be the best option for the patient. Already in the 90s, the laparoscopic sigmoid resection came up, and it's supposed to be the standard procedure now. In 2009, a publication in the Annals of Surgery could show a 50% reduction in major morbidity, less pain, shorter hospitalization, and a significant improved quality of life for all these patients. But what are you going to do with this? So you open the abdomen, you have a septic patient, it's 2 o'clock in the night, the anesthetist is not really happy with you. You might be a general surgeon, no colorectal surgeon. How do you deal with that? Well, probably everybody would say Hartmann's. What else? Think about damage control surgery. Well, we heard about it. Damage control surgery in this case is a concept of abbreviated laparotomy designed to prioritize short-term recovery over the anatomical reconstruction. So there was a group in Innsbruck, Professor Oefner and his guys started with that to think about it because of the conditions we are facing during the night or during the night shift, or especially on the weekends as well. So Peradonna published it in 2010 in the colorectal disease. The concept, they did a damage control with a lavage, a limited resection of the diseased colon, no stoma, no anastomosis, and they put a negative pressure therapy into the abdomen. They brought the patient back to ICU, and then afterwards, 48 to 72 hours later to the theater with a delayed anastomosis with advanced peritonitis or septic shock. So they collected their data from October 26 to September 28. They had about 27 patients. And the result was that of those who survived, the rate of the anastomosis mounted up to 70%. So that means you only have 30% of patients who have a stoma. So think about Hartmann's, 100%. And then if you have the Hartmann's, what are you going to do with this stoma? Loads of these patients have big problems with their stoma, and afterwards the Hartmann reversal sometimes can be a big mess as well. So once again a slide, the 27 patients and 60 of them were alive with the stoma. Some were dead, some couldn't survive because of the sepsis, some had problems, and intraoperatively some of these were not able to do this, so they had to do a Hartmann as well. So, but look at that. You're probably not going to close the abdomen again. So your next step would be a negative pressure therapy. So there are 2 companies now. Is KCI, Acelity from the USA. They started with the VAC system, and I started with the VAC as well. Now some hospitals are using Aptera. You have to protect, you have a film or a foil to protect the bowel here. It's this. And then afterwards, on top you put the foam and you cover it with a plastic film, and then you connect it with a suction pump. The other company is from Austria, Germany. It's Lohmann-Rauscher, and it's this kind of device, more or less the same. So here you can see once again the film, then the foam, now taken off after the first second look. And here, the same thing, the different film. This is the Lohmann-Rauscher foil, which is quite nice. So, and if you're not able to close the abdomen at the second look operation 48 hours later, then you really should take care of the retraction of the rectum's muscle, because if not, then the patients will have a laparostoma, and you're not able to close it in the future if you're doing more sessions of negative pressure. So put dynamic fascial sutures which protect the muscle to retract. Here you can see once again taking the film off. That's the situation after 2 changes of the vac, and that's ready to close. So to sum up and to conclude, this kind of strategy is quite useful in Hinchi 3 and 4 patients with a septic shock and fecal peritonitis. The mortality is very high, so we have to think about bringing the patient really quickly back to the ICU and do the best for him. And then especially not only for the patient, for the surgeon as well. As I already said, not many general surgeons are feeling really comfortable if they don't have the experience at 2 o'clock in the morning with maybe a junior or a resident to perform an anastomosis. So, and to prevent patients from having Hartmann's stoma. So the damage control strategy combines all these requirements for these kind of emergency operations. It's short, it's effective in terms of eliminating the septic focus, and it's safe, and it's really easy to perform. So the advantages are a better patient selection for a definite reconstruction at the second look operation. So then at 10 o'clock or 11 o'clock in the morning next day, there might be a very sophisticated colorectal surgeon who is able to do a very nice anastomosis, and then, if so, do a loop ileostomy, which can be reverted very easy, and the complication rate is lesser than with a colostoma. And of course, the low stoma rate of overall about 50%, if you have a look at the newer publications, is out there. It can be easily performed by a general surgeon, as I stated before, and well, maybe someone thinks about changing their strategy and doing damage control in the future. Thank you very much.
Thank you, Professor Raymond. The time for Goma prayer. Okay, thank you very much.